First of all, I would like to thank the organizers for inviting me to this online conference. It's a great experience for me and the first time, so I hope it will be a success. I found the title of my presentation has given to me a tall order. The vast amount of publications that has come out of the research community is impossible to summarize in 30 minutes. And I have seen time and time again that new discoveries or insights bring even greater and unexpected level of complexity to light. Therefore, it is impossible for me to foretell the future of FSHD. Instead, I will give you a personal view on some aspects of FSHD, and I will emphasize my biases and my regrets that hopefully will inspire some of you to do better. Now, this is the first patient I saw with FSHD, a man of 35 years with a classical picture of the disease on a rather clumsy photograph. It's an old photograph, as you see. You cannot see his facial weakness, but you see his horizontal clavicles, the oblique axillary folds pointing to the pectoralis muscle atrophy, and the atrophy of the upper arm muscles, and with fairly normal deltoid muscles and lower arm muscles, leading in the past to the unkind summary of Popeye arms. In this picture, it's difficult to see that he has abdominal muscle weakness and foot extensor weakness. He knew that he had a muscle disease, but that was not the reason why he had come to the Neuromuscular Center in Amsterdam, where I worked at that time. He came with his son of 5 years, and he wanted to know whether his son had the same disease as he had. As you see, his son had a mild asymmetry of the position of his shoulder blades, prominent margins of his scapulae, and thin supra and infraspinatus muscles. He had no facial weakness. Now, before I answer you what we told the father, I'll give you a personal interpretation of some historical events. Landouzy and Desjardins described in detail, and for the first time in family with several members with FSHD. The news was that it was a myopathy and not a neuropathy, and that it was distinct from the only myopathy known at that time, which was Duchenne's dystrophy. The publication was in French, and most likely Oransky in Leningrad did not read French. The FSHD family he described in German was summarized as scapuloperoneal myopathy. And after that, the term scapuloperoneal created a life on its own and a lot of nosological confusion. Pearson, as you see, who probably had not read Landouzy and Desjardins' original papers, took the term facioscapulohumeral as a summary name of the disease and described in the English-American literature his discovery, namely that FSHD patients can have foot extensor weakness. Julia Bell studied cases of myopathy with facial muscle weakness from Queen Square Hospital in London, assumed that they were one disease, and applied for the first time Mendelian laws upon their pedigrees. This paper of her influenced Lord Walton, who wrote on the inheritance of muscular dystrophy. He concluded that FSHD can inherit as an autosomal dominant disease, as an autosomal recessive or X-linked recessive disease, and also has many phenocopies of undecided origin. Well, this was where we stood with the father and son that I just showed you. It was decided that I should see the family to find out the pattern of inheritance in this family, but the family was reluctant to come to the Neuromuscular Center, so I went to see them in their homes. This is the pedigree of the father's family. It shows a clear autosomal dominant inheritance. On that basis, it was concluded that the son most likely showed the beginning of the disease. The boy was followed for more than 15 years and seen by several neuromuscular experts who agreed upon the original conclusion. But at the age of 19, he still had very thin supraspinatus and infraspinatus muscles, but then genetic studies showed that he had no deletion and no FSHD. Now, this case made a big impression on me because it clearly showed the bias of a clinician when he expects the possibility of a disease. Now, if we had read Landouzy and Desjardins' original papers more carefully, we should have realized that the supra and infraspinatus often remain quite well developed and for a long time in FSHD. Now, similar cases stress the necessity for a proper genetic diagnosis. I would like to draw your attention to the many single persons without children in this pedigree. I will come back to this later. Also in this pedigree is this person designated A. She clearly had all signs of the disease in her facial and shoulder muscles, but could still lift her arms above shoulder level. She did not believe my diagnosis and stated rather forcefully that she had no complaints. Well, this led to some discussion, and in line with nosological definitions, we called her asymptomatic, meaning that she had signs that doctors could see and could agree upon as part of the disease, of which she had no complaints. That is, no symptoms. So symptomatic then means with complaints relevant to visible signs. Now, the first family I show you led to the examination of all the families of 19 probands with FSHD that were known at the Neuromuscular Center in Amsterdam. Genealogical studies showed that none of these probands were related. A bit peculiar, but the majority of probands were males. I've never asked them why they were referred to the center, and that's a regret. Only later, when we studied job perspectives, I assumed it was because of employability questions. Now, in these 19 families, we found 73 persons and symptomatic and 34 asymptomatic ones. Asymptomatic cases were found in each age group up to the 7th decade, and in such percentages that it suggested that signs appear in these persons, but never progress to such an extent that it lead to complaints. I was amazed when I saw this young man who had moderate facial weakness, scapula elata, and atrophy of the sternal parts of the pectoralis muscles, but no complaints of it. I never confronted these patients with my opinions. I should have asked further. This is a regret. Well, five persons were clinically equivocal and were left out of the study. With hindsight, some of them could have been non-penetrant cases. I come back to this later. Even more amazing is why the 54 symptomatic family members had never been seen at the Neuromuscular Center. I never asked, another regret. These families led to the location of the gene, then to the Z4 repeat, and then to a reliable genetic diagnosis. And the genetic diagnosis solved several questions that I had with some of the pedigrees. For instance, as you see here, somatic mosaicism, germline mosaicism, and germ cell mutations. And in the end, the genetic diagnostics solved the outstanding questions in Lord Walton's publication on inheritance. Much later, I asked Dr. Wolgemuth, who did a similar study in another 10 families, to commit herself to label all SIBs to yes or no clinically affected. She labeled, as you can see, 4 SIBs affected who tested genetically negative. They all had subtle asymmetric muscle features. It showed that you risk a 5% false positivity by clinical testing if you expect the disease to be possibly present. Now, the study was set up to find the non-penetrant cases in families with a range of residual repeats. As you see, 13% of SIBs with no signs tested genetically positive. This slide also shows that when you accept only advanced signs as a positive clinical diagnosis, you end up with a high number of non-penetrant cases. Now, based on these 150 SIBs from those 10 families, Wolgemuth calculated the likelihood of developing signs of the disease with different repeat sizes. And remember, all these likelihoods include 20 to 30% chance of being asymptomatic. So the left side of the panel represents non-penetrance and therefore shows that non-penetrance depends on repeat size and age, and as said before, on the amount of physical signs that the doctor accepts as sufficient for the clinical diagnosis. The weak part of this study is that SIPs younger than 18 were not allowed to be included, so that the dotted lines represent some, well, incomplete, probably a bias. So what we know about population, there's a rarity of large families. On average, 5 to 6 living affected members per family are found. There's a normal fertility rate, a normal survival rate, and not a lethal gene. 30% of the affected families and family members remain childless. I think it's a cultural effect. There's a tendency of smaller families at present, which is also a cultural effect. We see frequent isolated cases. By definition, we don't know anything about their offspring. There's a high mutation frequency, and we found anticipation very unlikely because we saw many members symptomatic who had asymptomatic children older than 30 years. Now, this leads to the following hypothesis. FSHD disappears out of families because of cultural reasons. Non-penetrance cases disappear in the population pool of non-manifesting carriers of deletions. This population is imbalanced by expansion of repeat via gene conversion with interchromatid crossover. And the proof of this hypothesis I leave to the geneticist. Now, one more family to make a point. The unmarried proband told me that no one in his family had his disease. I went to see his family. They lived on a farm. Along the driveway to the farm was a washing line hanging at chest height. The proband's mother explained to me that the washing line was hanging low because she had shoulder pain when raising her arms. It was rheumatism, she told me. That's what the GP had told her. And her peculiar face was just a family trait. I was not allowed to examine her physically, and at the neuromuscular center we had some discussion how to classify her, as pain at that time was not considered a diagnostic criterion. I'll come back to this in a second. In this family, I saw only affected persons who had no complaints or denied complaints or were unwilling to discuss the disease. Initially, I interpreted these reactions as possibly a cultural effect, but I encountered many similar reactions in other families. I asked myself whether this was some form of anosognosia, denial of illness. Now, Carantelli published a study on cortical gray matter loss in patients with FSHD. The loss in the precentral cortex on the left side was brought in relationship with the presumed predominant right-sided muscle weakness. But the loss in the cingulate gyrus was not explained. And this area, among other functions, is often implicated in studies of patients with chronic pain. And the right-sided frontopolar and orbital region is implicated in studies on the concept of self and bodily perception, and in a deficit sense to anosognosia and disease denial, as can be seen in Alzheimer's disease. Unfortunately, the patients enrolled in this study were poorly characterized, so this study needs to be replicated. Questionnaires on anosognosia are available, and we should have done this. So again, this is a regret. There are several other studies on CNS function in FSHD. Most of them are single studies and are in need of confirmation. The study on cognitive dysfunction in families with large deletions has not been repeated. The issue of depression is controversial, and the brainstem evoked potentials might be relevant for the discussion on hearing loss. Should be repeated. In a transcranial magnetic stimulation study, a decreased intercortical inhibition was suggested as a possible cause of reported epilepsy in FSHD, and the central activation failure was considered a contributing factor in the experienced fatigue. Now, You can summarize all these studies in this cartoon that paints brain functions as heavily contributing to FSHD. The middle section refers to the patient's perspective as the sum of many contributing factors. I will not talk about fatigue, where muscle weakness and central activation failure contribute, but also pain and disturbed sleep. I will not talk about sleep, where pain and respiratory muscle weakness have been reported as contributing factors. A possible contributing of brain on sleep and pain has not been investigated. I come back to pain in a second. Around this cartoon, you can sketch genetic and molecular factors contributing to the total picture. And the brain also offers you the possibility of entrance of cognition and societal factors into the picture. And finally, when you do trials, remember the placebo effects play out through the brain. Now, regarding pain, we have more than 20 studies available. Up to 90% of patients report pain. In contrast, the 10% of patients who do not report pain are an interesting group for scientific reasons. The most severe pains are reported in the neck and shoulders, as you see on this picture, and in the lower back. More than 25% of patients report chronic pain lasting more than 3 months. And the pain pattern appears to reflect the neuromuscular price humans pay for the evolutionary ascent in order to stand upright, reach the arms high for the forbidden fruit, and express their emotions in their faces. What we are missing is a characterization of pain along the standardized protocols of QST, supported by laboratory studies such as evoked potentials, MRI, PET scans. This is important because many ligands and their receptors are involved in different types of pain, and therapies are being developed for each of these receptors. We should have done these studies some time ago. That's a regret. Now I would like to turn to semantics. It is often written that there is a great variability of muscle weakness in FSHD. And such a statement pains a clinician because it might imply there is no characteristic pattern of muscle involvement. Instead, there is a highly specific pattern, otherwise we would have never been able to recognize FSHD as an entity. The only thing that is a variable is the rate of progression of muscle involvement. And this cartoon that is so often used reflects therefore a certain stage of this progression. A muscle that's specifically spared for a long time is the deltoid muscle, which happens in no other muscle disease with shoulder girdle involvement. And the strong deltoid pulls the unrestrained scapula visibly above shoulder level, which is a very characteristic feature of FSHD. An explanation for this picture is at present beyond our grasp because we do not know how the individual muscles are laid down in early embryogenesis, how their place, form, and functions are determined, and specifically what protects them from deteriorating early in the course of the disease. Now, Mull addressed this problem in a paper in Clinical Genetics. She looked at the relationship between the phenotype and genetic characteristics, such as repeat length and repeat methylation. Now, the repeat length explained only 10% of the variance of the clinical score, while family factors such as kin relationship explained 50% of the variance. And when she looked at the repeat effects on the various compartments of the clinical score, she found that the repeat explained 30% of the variance of the facial muscles, 15% of the upper extremity, and only 3% of the lower extremity, implying that many other factors within the family constitution determine the appearance and severity of the disease. So it appears that DUX4 has no effect on the body plan. It does have an effect on satellite cell differentiation, and the remaining question is whether it has an effect on satellite cell proliferation. Now let's have a quick look at the facial weakness. Facial weakness is recognized by doctors in 80 to 95% of patients. Now, the question is when you decide that there is no facial weakness. The man who closes his eyes cannot bury his eyelashes on the left side. Asymmetry helped a panel of doctors to make the correct diagnosis. But when in both eyes the lashes are still not visible, it was often considered weak. The boy on the right was frequently rated as mild orbicularis oculi weakness, while in fact he had a complete paralysis of his muscle, and what you see is a relaxation of his levator palpebrae. And the smiling lady was rated more often as normal when doctors were told she was a control person. So the rating and quantification is a problem. Facial weakness is often tested by functions that children have to learn, such as whistling, pouting, blowing balloons. And early diagnosis is only made when there's considerable weakness and an attentive mother notices that the child sleeps with the eyes open. Furthermore, a normal population, facial asymmetry is occasionally present. The experience with FSHD families clearly shows that facial weakness often goes unnoticed. Therefore, I think that self-reported facial weakness, or the absence of it, is an extremely unreliable item and not suited to counsel on prognosis. And the last question is whether facial weakness is a progressive disorder or a stationary condition. In my experience, I have seen no one progressing in a lifetime to total facial paralysis. Faces do change over time, but in my experience, more due to changes in the skin and subcutaneous tissue. So with an uncertain beginning, due to the way the muscle's function is studied, and uncertain about its nature, we are in need of an agreement on the definition and quantification of facial weakness, a natural history study and longitudinal observations, and biomarkers, such as MRI and echo are needed, and muscle pathology. And while the SDF and the PITX2 pathway are both involved in the development of facial muscles and in the left-right body axis formation, the relationship with DUX4 needs to be more explained. Is this important? Maybe, if we ever arrive at stem cell therapy. Now, the shoulder weakness raises similar questions. We do not know the original condition of the shoulder muscles before they become visibly weak. And the weakness often remains undiagnosed or undecided for a long time. The frequent asymmetry helps in making the diagnosis. The cause of the asymmetry is unknown, but the same genes, SDF and PITX2, are suggested but presently unproved. Arashiro reported chemokine production in asymptomatic patients. In a footnote in her paper, she states that none of the patients had signs of the disease. Whatever the precise condition of her patients, the paper suggests that chemokine production might be an early phase in the muscle pathology. This could be in agreement with some chemokines as painful stimuli, and the mention by Dr. Wolgemuth that some of her non-penetrant cases reported painful shoulders. On the background is an old discussion whether FSHD is a focal or generalized myopathy. It was known for a time that when you take a biopsy from a clinically normal muscle, you could end up with a normal looking muscle morphology. And related to the question of focality was the question whether shoulder muscles are always the earliest manifestation in FSHD. In my experience, and supported by many case reports, when lower limb weakness is reported as first symptom of the disease, you always find a distinct shoulder girdle weakness as well, which, as in many other instances, often goes unnoticed. Now, when you look at severely affected early onset cases, such as this young boy, you get the impression that you look at a generalized myopathy, although with a descending gradient of severity. So the question I would like to raise is whether FSHD muscles are laid down in development as strongly as in controls. I appreciate there cannot be much difference as motor milestones of child development appear not delayed. However, Brouwer suggested measured strength in the lower arm and hands muscles. He measured them in 53 patients and found a significant right and left hand weakness in both men and women. This is shown in the upper part of the panel. In 1992, this was taken as a subclinical onset of a progressive generalized myopathy, and the question whether this weakness might be congenital was not raised. Now, Mara measured in the lower part of the panel, measured the strength in Newton per cross-sectional muscle area in the quadriceps after correction for fat infiltration as seen on muscle MRI. FSHD patients generally generated less strength per cross-sectional muscle unit than healthy controls. There are many pitfalls in the interpretation of these results. However, it seems obviously that examination of minimally affected or non-penetrant persons might give some answer. Is this relevant? Conceptually, yes, and possibly practically as well. If FSHD patients are congenitally somewhat weaker than the normal population, you might not want to aim for equal strength in patients compared to controls when you do clinical trials. Now let's have a quick look at muscle pathology. A biopsy of a weak muscle might look as in the upper panel. You see small fibers, big fibers, hypertrophic fibers, fibrosis, fat, and small infiltrates. Now when you order the abnormalities in according to their frequencies, variation of fiber size is number one. Fibrosis is much more common than infiltrate, so it might be possible that an extracellular matrix process is an earlier event in the pathogenesis than the inflammatory changes. The fibers on the lower panel were first described by Bedlam as lobulated fibers, thought to be a biomarker for FSHD. Later publications thought they were the same as moth-eaten fibers and suggested mitochondrial abnormalities as its cause. Yet this issue has not been well explored. This is a small regret. Now, Stepland reported on tunnel-positive nuclei underpinning apoptosis as a cause of cell death, and he reported reduced median capillary density. I come back to this in a second. Now, based on pathology frequencies, I would like to speculate a bit. Assuming fiber hypertrophy is a reflection of muscle hypertrophy that occurs in some muscles, for instance, in the extensor digitorum brevis as a compensation for anterior tibialis weakness, and in the infraspinatus, as I showed you before, it suggests to me that the follistatin pathway is still important to keep in mind as a possible therapeutic strategy. Chemokines as suggested by Arashiro and the membrane attack complex as shown by Wang point to pathologies prior to perivascular infiltrates. And finally, if there's a reduced capillary density in FSHD muscles, and if this occurs in a proximal to distal gradient, it would fit the near-infrared spectroscopy study showing a reduced oxygenation distally, which again might fit the distal to proximal gradient of fatty infiltration. And if the muscle capillaries reflect the congenital loss of capillary density in the retina, possibly caused by endothelial tip dysfunction, we are back in the same pathways as implied in facial pathology. Now, then allow me to bring a simple hypothesis. DUX4 lays down in embryological phase an epigenetic descending susceptibility gradient, which at the cellular level might be visible as a reduced differentiation and possibly proliferation capacity of satellite cells. This leads to pathology after puberty when the satellite cells are exhausted to fulfill muscle growth, and muscle damage occurs first in the scapular fixators due to eccentric muscle contractions and damage that cannot be adequately compensated. And now this final slide brings me back to the nosology of FSHD it has a recognizable phenotype and only one major variable, the rate of progression. It has a single pattern of inheritance, a common genetic cause, and a specific pathogenesis. And finally, microscopic findings that have little in common with other dystrophies, except for the common final event of necrosis. Therefore, FSHD has all nosological requirements to call it a disease, facioscapulohumeral disease. Thank you very much for your attention.